Welcome to the Cataraqui Woods Dental Implant Institute, a nonprofit organization with the mission and vision of furthering both education and research in the field of oral implantology. My name is Dr. Waji Khan. I'm a dental surgeon and also the course director for a series of online lectures provided as a service to the profession of dentistry to deliver a literature and knowledge-based approach to dental implant education for practitioners interested in learning more about how to implement the discipline of oral implantology into their clinical practice. This online course should be merged with a suitable clinical course and long-term mentorship study club program so that the learner can maximize their benefit from the didactic online program. The production of this series of lectures was partially funded by an educational grant from the International Dental Implant Academy. Lecture 12, The Management of Complications. Now, for those of you who are watch gurus, you'll recognize this timepiece here. This is a Frank Mueller watch. It's a Swiss watch, and this watch is called the Master of Complications. I love this watch. For any of you who are considering buying me a gift, here's a nice hint for you. I don't currently own this watch. What I love about this watch is the number of complications that are inside of it. It truly is a technical masterpiece. These days we have these wonderful watches that come from Japan, these analog watches, digital watches that are very, very accurate. There's iPhone watches and iWatches, or I think the Apple Watch is what they call it. However, nothing quite gets me excited as much as seeing this gorgeous timepiece, the Master of Complications. And unfortunately, it's the only complication I probably don't have. One of the things about practicing dentistry is that things can always not necessarily go the way that we want it to go. Dentists, as people, we don't necessarily like paradigm shifts. We like doing things a certain way and consistently achieving the same result. Unfortunately, with implant dentistry, the number of permutations and combinations of things that can occur, notwithstanding variations that exist within patients themselves, complications is just something you're going to have to learn to deal with. And how complications are dealt with becomes a bit of a practice management issue and also a patient relations issue. Most complications are fairly benign and they can be dealt with in a very simple manner. However, let's begin our discussion of this. But actually, prior to starting that, let's take a look at a few famous quotes about life in general. So Nora Roberts once said that nothing worthwhile is ever without complications. History, as well as life itself, is complicated. Neither life nor history is an enterprise for those who seek simplicity and consistency. This was Jared Diamond in Collapse, How Societies Choose to Fail or Succeed. One of the quotes in French from a letter to Armand Barbe in 1867 from George Sand, he says, "Le frais est trop simple, il faut y arriver toujours par le compliqué." The translation is, the truth is too simple, one must always get there by a complicated route. And finally, Maureen McHugh, after the apocalypse, said, "Staying married to one person was boring." She figured she was too complicated for that. Interesting people had complicated lives. So complications happen. We say that in dental implantology, that the success rate of 95% is in ideal cases. Ideals, as we defined in the previous lecture, in terms of the implant success rate, or the definition that Dr. Karl Marx had proposed about being implant success, implant survival where things aren't compromised, implant survival where things are compromised, and failure. So complications are reported by McDermott in the International Journal of Oral Maxillofacial Implants in 2003 to be around 13.9% of all cases. And of this number, about 1% are operative complications, about 10.2% are inflammatory complications, and about 2.7% are prosthetic complications. Any type of complication, however, if not recognized and dealt with early on, can lead to poor treatment outcomes. So how can we plan to avoid them? So our outline of the lecture today is basically to talk about a definition, a categorization of the types of complications that can occur. And these are going to be defined as A, treatment plan related, B, procedure related, C, anatomy related, and D, iatrogenic. There are other forms of categorizing types of complications as well. Treatment plan related complications are basically summarized as wrong angulation, wrong location, lack of communication. Part B, procedure related complications are defined as lack of primary stability, mechanical complications, mandibular fracture, ingestion or aspiration, infection, fistula formation, and loose screws, and implant failure, and anesthesia problems. Part C, anatomy related, we have nerve injury or paresthesia, bleeding, cortical plate perforation, antral or nasal perforation, devitalization of adjacent teeth, a lack of attached tissue, and wound dehiscence. And finally, in terms of iatrogenic errors or iatrogenic failures or complications, we have human error, issues related to patient selection, issues related to prosthetic failures, and finally, the grim reaper of dentistry, parafunctional habits. So other complications, as groupings as mentioned, are preoperative, perioperative, and postoperative. Some people like to define complications as transient, persistent, or permanent. Other people like to define complications a little more simply in terms of soft tissue complications or hard tissue complications. So we'll start off with part A, which was treatment plan. We're going to start off here with just a discussion of periimplantitis. So most of you who went into this lecture talking about complications for implantology are probably wondering, how come you didn't list periimplantitis in there, or periimplant mucositis, or periimplant diseases? Perhaps this is the most important long-term complication, and as such, it's worthy enough to be devoted its own presentation, which will be the next presentation. So let's start off with treatment plan related complications, wrong angulation. So implant angulation is a determinant of implant success as it determines how the implant is loaded. We know from our initial lectures that implants like vertical forces. Implants do not like horizontal forces. There is no shock absorber periodontal ligament inside an implant. And as such, any sort of horizontal force or excessive horizontal force is going to result in bone loss. The buccolingual, apical coronal, and mesiodistal angulation of placement of the implant are thus important. Placing an implant based upon the availability of bone is a recipe for failure. And we can talk about failure in terms of two things, in terms of both aesthetics and also biomechanical stability of the prosthetic. As we said back in one of the earlier lectures, that implant dentistry is a prosthetically driven surgical discipline, and you can't forget about that. So if it's the case that the bone is in one place and the prosthesis needs to be in another place, from a long-term perspective, what you need to consider is, do we need to graft this patient? Is a bone graft required? Is some type of soft tissue grafting required in order to get the aesthetic and biomechanical stability for this prosthesis in the long term? And if the answer is yes, then let's do it. And if the answer is we can't do it because we're limited either by patient finances or patient's health or other issues, then the question is, why are we going to be placing implants inside this patient? Let's look at other treatment options. So here's a picture of basically a placement of the initial stages of placing an implant, and we've talked in the past about placing a pin or a guide pin in and taking a radiograph to ensure that one has the proper angulation. Now, obviously in this photograph, you could be perfing out the buccal or the lingual and no one would ever know. Well, in an ideal sense, you're taking your fingers, your thumb and your index finger, and you can sort of have an idea of where the bone is, or you've bone sounded it, or you have some sort of CT or other advanced imaging format if you're in doubt about those positions. But we have these intraoral periapicals that are available to us intraoperatively in order to use as a guide to ensure that we are going in the direction in which we want to go. Let's take a look at a few other pictures here. In this photograph here, a patient had a tooth taken out, and we were planning to place what looks like a 14 millimeter by 4.5 millimeter implant. So let's start our osteotomy in this patient. As we know, where the root used to be is going to be the path of least resistance, and that's the area in which the drill is going to want to take us. And unfortunately, as a result, that can lead to things like, take a look right here. So the pin was going, it looks like parallel to the patient's cuspid. However, it's not necessarily in the ideal position from a masticatory perspective, and also from a prosthetic perspective when one's going to consider where this cover screw, sorry, not the cover screw, the actual orifice for the screw retained crown is going to be. It's too close to the mesial aspect of that second bicuspid. So by taking this radiograph, we have the ability to move the osteotomy, to get some distal tip on this osteotomy, and you'll see in the next picture that this was corrected prior to placement of the implant and the healing abutment. The solution can be partially dealt with by using a rescue technique like a custom abutment if the implant's already been placed. However, we don't need to do that. Why are we going to do that when we have things like surgical guides that can help us avoid these dilemmas? Especially if guides have long guide channels, they will avoid intraoperative deviations. Guides with no channels, like some of the computer-aided guides, provide little guidance with respect to angulation without the use of a sleeve. And as you can see here, we talk about using custom abutments as a rescue technique, but I mean, okay, all right, well, the picture on the top left there, if you had a patient with a high smile line, would you consider that a success? I don't think so. I'd consider that a failure. I'd lose sleep over that. I mean, I'd feel terrible to subject a patient to that. Or look at the picture in the middle, or the picture on the bottom right. So the other thing about putting the implant at the wrong angulation, sometimes it can be an intraoperative or an operative technique issue. So things like using a finger rest. Now in dentistry, we've been taught to use a finger rest to steady our hands and use the small muscles that give us our fine dexterity and help us prepare those nice class 1, class 2 restorations with using very, very small instruments. However, when doing implant dentistry, you're using this huge drill. So if you're going to use a finger rest, the natural tendency of the motion is going to be for the drill angle towards the hand which is drilling, due merely to the length of the implant drill and the natural movement of the hand. So one needs to be cognizant of this when they are placing an implant. And unfortunately, bad things like this can happen. So the other thing about treatment plan related complications, we're going to talk about wrong location. So ideally you want to give yourself at least 1.5 millimeters away from teeth from the body of the implant. So we're talking about the root here. Now in the natural world, teeth, they sometimes you can get consequences of the roots. You can get roots that are very close in proximity to one another. And in the reality is sometimes you're going to end up placing implants in very close proximity to the roots. However, one needs to be wary of the fact that when you have very little space, you want to be that much more diligent with respect to your intraoperative radiographs to ensure that you're giving yourself enough space from the root, and you're not going to end up causing compression necrosis of the periodontal ligament or the bone adjacent to that tooth, or adjacent to that implant, the tooth adjacent to the implant, and ending up causing periodontal issues for this patient, or worst case scenario, devascularization of that tooth and requirements for either endodontic treatment or worst case scenario extraction. You want to give yourself at least 3 to 4 millimeters between implants, and this is just to prevent things like compression necrosis of the bone, to ensure that there's going to be sufficient bone between the implants. The study by Tarnow basically determined that it doesn't matter what the distance is between the implants, you can still form papillae between them. This 3 to 4 millimeters is more just to guarantee that there's going to be bone. You want to give yourself at least 10 millimeters from the opposing arch. Implants aren't just going to sort of have an implant and like a 1 millimeter crown on top. You need to have at least room for the implant, for the abutment, for the prosthesis that's going to be going on top. We know that yes, we can make a metal crown with 1 millimeter clearance. However, would you want to give yourself 1 millimeter clearance on a crown? Probably not. So try to make sure you have at least 10 millimeters from the opposing arch. Sometimes if you're replacing a lower tooth and the upper tooth is extruded out, there's nothing wrong with considering perhaps reduction of the occlusion of that tooth in order to give yourself more clearance. Sometimes if it's excessive reduction, that tooth may require endodontic treatment, prophylactic endodontic treatment, and restoration with a crown in itself. These are conversations you need to have with the patient, and it might be the case the patient says, you know what, I'm not really missing that bottom tooth that much, as compared to placing the implant and then going back afterwards when you're getting a call from your lab telling you that you don't have enough clearance, and having to go back and have the difficult conversation with the patient and letting them know that the only way you can restore that implant is by doing an endo and a crown on the opposing arch. And if this is a conversation which is taking place after the fact, worst case scenario, you have a patient who gets really angry and says, you know what, had I known that, I wouldn't have done this. So placing an implant in the wrong position can become a frustrating, embarrassing, and foreseeable complication. Once again, we take a look here where we talk about that, the ultimate unfortunate situation here in which an implant was placed too close to the root of a tooth, and it caused devascularization of the tooth and an endoperial lesion. So these issues can be avoided by communication, diagnostic wax-ups, the use of stents, and the use of verification radiographs intraoperatively. The largest problem with space between implants is the development of the papillae, especially in high aesthetic areas. So studies from Tarnow, as we discussed, basically demonstrate that so long as the distance from the contact point to the crestal level of the bone is 5 millimeters or less, it does not matter how far apart the implants are. So you take a look at this picture here, we see that there's some weird angulation going on with the roots here. They're kind of mesially tipped, and there's a bit of an overhang there on the mesial aspect of that first lower left molar. So, this is actually myself placing this implant. So in this case here, I said, okay, you know what, I placed a ton of implants. However, I wouldn't mind taking an intraoperative radiograph just to make sure, and here we go. Yep, I seem to be in the position that I want to be in, except for I left that overhang, and you'll see that in the final radiograph, when we actually restored the implant, that the implant's in at the proper angulation. We got rid of that overhang on the mesial aspect of that bottom left first molar, and that the triangles, those little black triangles that end up forming the soft tissue that's going to caress this implant, are of an adequate shape. This isn't going to end up being what they call a lunchbox prosthetic, is a prosthetic in which the patient's going to be consistently building up food and debris and causing detriment to their oral hygiene and also to their other teeth. So we take a look at this photograph here, not to become repetitive, once again taking a look at a first premolar. Now, a first premolar, I'm going to warn you, is actually a very, very difficult site to place a implant in. So the first upper premolars, they're difficult because of the angulation that the canine tooth sometimes takes. And also from a radiographic perspective, in terms of getting an accurate radiograph here, this is right on that turn inside the mouth. So sometimes our assistants, they won't necessarily get the proper angulation here. So one has to be very wary of the preoperative and intraoperative radiographs that they're using in this sort of a case. So you'll take a look here. I did my primary osteotomy and use the direction pin indicator, and here we go. There's a look at that. And intraoperatively, what does this look like inside the patient? So you can see there's the primary osteotomy with a full thickness flap, and there's the picture of the pin. You already saw the radiograph of the pin. So the other thing about treatment plan related complications, we need to look at the lack of communication. So it's sometimes between the oral health care professionals, that being the denture care specialist, the surgical dentist or the surgeon, the restorative dentist or the prosthodontist, or whoever's going to be working on the team here. There needs to be a quarterback, and nobody can assume. Everybody knows what assume does. Assume says it all. With patients, there needs to be communication, and this is usually conducted via the consent process, which usually involves a discussion of the procedures and the material risks involved. So pain, bleeding, infection, failure of the implants, and also answering specific questions for the patient. We talked about this in the lecture dealing with consent law. It's also suggested that other topics include things like swelling, discoloration, paresthesia, neuralgia, fracture, joint pain, muscle spasm, tooth looseness, sensitivity, recession, speech changes, trismus, and swallowing of foreign objects. As well, it's very important to also give out emergency contact information to patients in case some complication does occur, that they know how to get a hold of you. You'd rather them get a hold of you than march down to the emergency room or to another dentist's office, and then everyone's trying to track you down, trying to figure out where things are. It's easier to give them your number, have the patients give you a call, clarify things. I once had a patient give me a call 2 days after having a bunch of teeth taken out, having a bunch of implants placed, because the patient's husband basically was of the opinion that this patient should be NPO for 7 days. I wanted to see the patient 7 days later. So she called me back on day 2, and she said she was starving. How is she supposed to not eat for 7 days? And I was shocked. I was like, I never told you can't eat for 7 days. Basically, one of my assistants had told her or advised her you shouldn't eat until the anesthesia comes out. And her husband basically took that as don't eat until you come back to see me for the follow-up appointment. So making sure that that post-operative instructions are clear and that patients understand them, but also ensuring that should patients have any questions, queries, concerns, comments, that there is some means by which they can get a hold of you to ask. I would have been devastated if this patient came back after 7 days and informed me that they hadn't eaten. Not only is that a terrible, terrible situation to be in, we've just operated on this poor person, and this individual needs to eat in order for the body to start healing. So we're going to talk about the part B now. So we talked about treatment plan related complications. This is more procedure related complications. So this is lack of primary stability. So we need stability, primary stability basically to help ensure that no movement occurs, which is required for appropriate bone healing. If you do get movement, this can basically lead to the development of a fibrous encapsulation around the implant or a soft tissue attachment. And as we talked about in lecture 1, soft tissue attachments can work in the short term, but they have horrible long-term success rates. And usually the lack of primary stability is due to things like over-preparation of your osteotomy or using the wrong implant size. As well, in terms of procedure-related complications, we have mechanical complications. The biggest mechanical complication in the surgical process is overheating of the bone. So this is why we use copious amounts of irrigation when we are drilling bone. We know that from a study from Erickson in 1983 that bone resorption occurs at 47 degrees Celsius when drilling bone in a rabbit for 1 minute. So bone necrosis can cause problems for osseointegration. Cortical bone is even harder than the cancellous bone and requires more pressure to drill. As such, one should be using even more irrigation when one is drilling the cortical bone. The recommendations are basically copious irrigation and up and down movements, pumping that drill up and down in order to get the remnants that have been coming off that drill, so the shards of bone that have been collecting on that drill, getting those off, but also pumping more irrigant down into the area where the drill is actively working. It's also advised to tap dense bone to allow a more passive fit, which prevents microfracture, compression, necrosis, and it also helps remove some of the drill remnants prior to placement of that implant. I have a colleague of mine actually who does cool down his irrigation fluid. So he basically takes a bottle of his sterile saline and keeps it in a fridge just to keep it even that much more cool, so that when he's irrigating his implant sites, it just helps keep everything at a more natural temperature and preventing things from getting to that 47 degrees Celsius mark. In terms of procedure-related complications, one that I have not seen in my career, I'm hoping that this is one of those things where if someone says you haven't seen a mandibular fracture yet, you haven't done enough implants. If I ever have to see a mandibular fracture, I will not be a happy camper. Severely atrophic mandibles have an increased risk of fracture, especially when placing monocortical grafts or doing ridge splitting procedures. So this is a word of warning to the novice implant surgeon. If it's the case that you're going to be trying a procedure like this, you probably don't want to start on a patient who has a severely atrophic mandible. You probably also want to stay away from patients who have osteomalacia, patients who have osteoporosis, or patients who have uncontrolled diabetes. The goals of fracture care are basically reduction and fixation of the fractured segments. If anybody has not taken a course in the management of fractures, AONA, so AO North America, runs an excellent course. It's called Principles of Craniomaxillofacial Surgery, and it's run out of a number of locations in North America. You get to do all types of cool things and meet plastic surgeons, ENT surgeons, oral maxillofacial surgeons, and whatnot. And they go over the latest in research with respect to management of mandibular fractures. You get to play around on a number of what they call sawbones, and basically do like the Champy technique, the angle of mandible technique, use a 2.4 millimeter locking plate, play around with the various screws and other fixation devices. My favorite was the orbital floor repair. I don't think I'll ever be doing an orbital floor repair in my career, but it was just kind of neat to learn. So if you've never taken this course, check out this website. It's a great course to take, and you get to meet some really neat people. In terms of procedure-related complications, ingestion or aspiration. So we play with all types of small items in implant dentistry, from the little drills and the insertion tools to the actual implants themselves, to the cover screws, the healing abutments, the transfer copings, the abutment analogs. I mean, there's a gazillion small things that we're using inside a patient's mouth. And there's always a chance that things are going to basically slip out of our hands and are going to fall in the back of a patient's oropharyngeal complex. Now, most of the patients I work on, they're not sedated. And the main reason is because I like having my patients with their gag reflex and their other protective reflexes intact. And so if they feel something in the back of their throat, they can do a sit-up, pop it out of their mouth, and hand it right back to me. However, if you're sedating a patient, one needs to be cognizant of the fact that using things like gauze throat screens and floss ligatures around some of these smaller components is probably best practice. Worst case scenario, a patient does swallow an item. You're going to hope that they swallowed it and it's going to pass. You're going to hope that they didn't aspirate it. If they did aspirate, it's more than likely going to be down the right main stem bronchus. And in this sort of case, you need to get a chest X-ray to rule out the fact that it's been aspirated as opposed to swallowed. And this will basically, a chest X-ray will basically show that the items in sort of either the esophagus or in the stomach, as compared to being in the right or left main stem bronchus or other aspect of the bronchial tree. We covered this complication, or at least management of it, a little bit more in the medical emergencies lecture. Procedure-related complications, infection. So infection can occur in both the short and the long term. So in terms of short term, there's three cardinal things that we look for in terms of management of any infection, or the trilogy of the management of infection is we say there has to be appropriate antibiotic coverage for the patient, that there has to be some sort of drainage and irrigation, and finally there has to be removal of the cause of the infection. So the majority of infections that are going to occur are going to be subperiosteal infections. You were doing a procedure, you left something under the flap that you weren't supposed to, and this is going to come back as a post-operative infection. So the solution for this intraoperatively is copious amounts of irrigation. Make sure you're inspecting underneath those flaps and irrigating them like it's going out of style. There's an old expression in medicine. It says the solution for pollution is dilution, and that basically means dilute the concentration of whatever the offending agent is, or irrigate is basically what they're trying to say, and it will make things get better. Procedure-related complications, loose screws. So the main cause of loose screws is usually not retorquing them after being initially torqued. Well, remember that when we go to our car dealers, or getting our tires changed or rotated or whatever we do, they always advise us to go for a drive for about 100 kilometers and come back in order to have our tires retorqued. So in terms of torquing implants, you can torque them to like 80 Newton centimeters, but I mean, you're going to end up breaking the screw. So we torqued them to around 30 Newton centimeters, as this was a torque found at which you are likely to get less breakage of the screw, but it's not likely to loosen. However, we do know that like when you're doing, if you've ever had a chance to do wire ligation, putting in arch bars for a patient, you'll know that the first thing that these oral surgeons do is they lengthen their wire. So they grab the wire and they basically grab it between two bird beak pliers and they stretch it. There's this amazing, crazy amount of stretch to these wires that you use to ligate these arch bars. And one of the surgeons I was training with, he basically told me that if you don't do this, what ends up happening is you end up tightening these arch bars in these patients who have mandibular fractures, and they come back a week later and they're talking to you because of the stretch that takes place. So one needs to be cognizant of this. Somebody has termed this what they call the settling effect. Some people will say even that when a screw gets loose, you shouldn't use the same screw. Of course it's okay to use the same screw. Basically, it's the same thing as having retorqued it. So in our office, what we do is we basically will torque our implant screw down to 30 Newton centimeters, and then go for a coffee, have a chat with the patient, go see what somebody else is doing, go follow up on something else you need to do, come back after 10 minutes and retorque that implant, and you'll be amazed at the amount of rotation that you'll get even after having torqued that implant down to 30 Newton centimeters 10 minutes earlier. So by doing this, I've found, at least in my practice, that it's minimized the amount of patients who come back to have screws retorqued. And as I mentioned, some have termed this the settling effect. Part B, broken screws, so other procedure-related issues. So a study by Nergis et al. Stated that the primary reason for screw fracture is undetected screw loosening, which can be attributed to a number of things. So we're going to talk about bruxism, an unfavorable superstructure, overloading of the implant, or just malfunction. This is from Nergis et al. From the Journal of Prosthetic Dentistry in 2004. Broken screws are also more of a problem in the posterior region than the anterior region, and also in partially dentate patients as compared to completely edentulous patients. In this picture you see here, this is a patient of mine who many years ago we placed a couple of implants in its maxilla to help retain a removable prosthesis, and you can see there's an opposing natural dentition. You're probably wondering, okay, he's got an opposing natural dentition, which looks like he's got a fair amount of wear. The guy looks like a bit of a big hombre here. Why didn't you do 4 implants in a bar? In this patient's case, cost was a limiting factor, and so he sort of begged me, can you just do something for me? I said, okay, I can do this for you. You're gonna have to have a closed palate on your denture. You have to make sure you take your denture out at night. So the road to hell being lined with good intentions, he comes back to see me about a year later, and he's got this scalloping of the bone in and around both implants, and you see that, and that's probably due to just overloading of these implants. They're fairly large, robust implants. Nonetheless, they aren't, you know, they aren't implants that are not subject to the same laws of physics that other implants are. So this guy's obviously not taking his denture out at nighttime. And on the left side, you can see that in that first quadrant there, he basically loosened the locator screw abutment, and the screw basically broke off at that point where it is weakest. And so in this case, what we ended up doing was basically we were able to harvest the broken segment out. Some people say, well, hold on, didn't you torque it in there? Yes, we torqued it in there, but remember, the torque is a representation of that face, or in this case, this locator attachment sitting up against the surface of the implant. Once that breaks off, there's no longer any torque in here. These things twist out very easily. The key thing in these cases here is to get the patient in early, right? So ideally, you tell the patient to come in when the screw is loose, and you can tighten it before it breaks. Unfortunately, when it breaks, you want to get them in early too. Why? Because you don't want food, debris, plaque, calculus, and all those things basically mineralizing inside there, basically acting like a cement. If that occurs, you'll never get this screw piece out. So in this picture here, this is a patient who came to see me. She had this mini implant placed. As you can see, it's got a radiolucency around it. This was mobile, and she also had broken some of the attachments around her implants, and these had been broken for about a year before she came to see me. And here's a picture of what this looks like, and you can see that there's all types of just gunk inside there. We used ultrasonics on her. We used pretty much every tip trick out there to try to get these broken segments out, and we were unsuccessful. They weren't able to do anything for here. We basically had to accept these implants as a failure. So retrieval. So I'll be honest here with you, the only method of retrieval really is method 1. We're going to discuss 3 things here, but 2 and 3 are kind of like throwing a Hail Mary with 15 seconds to go in the Super Bowl and your team's down by 10 runs or 10 points. Method 1 is basically insert a very fine tipped hand instrument into the implant. I like using an Endo Explorer, and gently wedge it between the male and female threads. And with careful counterclockwise rotation, the fractured male thread can often be unscrewed and removed. And a variation of this method is to use an ultrasonic scaling tip on top of the screw head with a counterclockwise rotation. And the purpose of this ultrasonic scaling tip is to help break up some of the food particles and adhesions that can be inside there. Method 2 basically uses a small round burr with a high-speed handpiece and cut a shallow dimple into the top of the broken screw, using copious amounts of irrigation to keep this from overheating the implant during this portion of the process. You can also take a diamond or fluted end cutting burr, wedge it into the dimple, and then slowly rotate in reverse using moderate occlusal pressure. What I'm going to tell you is when you take a high-speed handpiece onto a drill bit, it's spinning clockwise, right? So when you're spinning clockwise, it's actually going to spin that implant broken piece further down. In an ideal world, they'd have a high-speed handpiece that functioned in reverse. Because try it out yourself sometime. Take a broken piece of off of a screw and start drilling on it. You'll see that it'll actually thread the thing down. Method 3 is to basically use a small diameter burr to cut a 1/2 to 1 millimeter deep slot in the top of the remaining male thread, and then using a small straight bladed screwdriver or dental instrument, which can be used to engage the slot to remove the screw. So as I mentioned, in my own experience, if method 1 does not work, method 2 and 3 are really hard, and the key thing is to get the patient in early. So this is a photograph of what a screw looks like without the crown or the abutment in place. And as you can see, that there's this little neck right there. So if this was become loose and that crown or abutment were to come outside of the facing of the implant or the surface of the implant, there's going to be the only thing holding it together is going to be that small little neck of the screw. And with movement back and forth, you eventually end up getting to the the failure point for this material. And what does it look like when it breaks? It looks like this. And as you can see, it's broken off, unfortunately, not in a nice place. You can see that this is an internal hex implant. If this was an external hex implant, good luck to you. You're not gonna get that out. In an internal hex implant, at least you still have this internal channel in which you can try to get a small tipped instrument in and try to rotate this out. I'm gonna try to get a video up on this page as well, just demonstrating this technique for you. Zimmer Dental also has a broken screw extractor kit available, which has 5 things: a claw reamer burr, a reverse cutting burr, a manual extractor, a deeper centering device, and a burr extension. It's a cool kit to have. I've tried it before. It doesn't work very well. The Hail Mary. So when all else fails, the screw can be cut out with an end cutting burr or fissure burr, basically destroying the threads of the implant. These threads or this area can then be smoothed out with a vertical cylinder diamond, ensuring that the walls are parallel without any undercuts. And then, you guessed it, you can now take an impression of this to make a cementable abutment post complex. So implant failure. What causes implant failure? Poor planning, poor healing, infection, thermal injury, the use of NSAIDs. Failing implants fail, unfortunately, and they require removal, and you can abandon them, pick an alternative site, pick a larger diameter implant for the area, or basically replace it after healing. Part C, nerve injury or paresthesia. So these are anatomical complications. So these can be avoided with proper treatment planning. The major victim of nerve injury usually is the inferior alveolar nerve, the mental nerve or the recurrent branch of the mental nerve, the incisive nerve, and the lingual nerve, though usually we're not placing implants in proximity to the anatomical region that the lingual nerve goes by. So here's a photograph of a radiograph of a patient in which the surgeon lost their reference point and basically ended up placing an implant too far apically and in close proximity to the inferior alveolar nerve. So if nerve injury is likely, this has to be discussed as part of the consent process along with treatment options and management. So possible causes of nerve injury could be poor flap design, a traumatic flap reflection, intraneural injection. So believe it or not, if you get that needle tip into the nerve, the actual injection will hydrodissect that nerve tissue, and this can potentially end up causing nerve injury. Traction on the nerve, penetration of the osteotomy, and finally compression of the implant body into the canal. So prevention, you can try infiltrating rather than using block anesthesia. You have to work on calibration of your software, making sure you don't lose your reference points when you're placing implants. Give yourself a 1 to 2 millimeter safety zone. I mean, hey, give yourself a 4 to 5 millimeter safety zone. If a patient has room for a 13 millimeter implant and the inferior alveolar nerve is at 15 millimeters, why not place a 10 millimeter implant? Give yourself lots of room. 10 millimeter implant in a particular case, it's going to work just as well as a 13 millimeter implant. I mean, notwithstanding, the patient's like a big person who's bruxing, that sort of stuff. But remember that the tip of the drill that you're going to be using is about 0.5 to 1.5 millimeters longer than the implant body. Take a radiograph. When in doubt, take a radiograph. It'll tell you exactly where you are. Also remember that you want to try to stay 3 millimeters anterior to the mental foramen. The mental foramen has that sort of recurrent anterior loop. So the mental nerve is actually going to be about 3 millimeters more mesial from where you radiographically see that mental foramen. So treatment. So how do you treat nerve injuries? So usually what we tell patients to take is anti-inflammatories, so 200 milligrams of Celebrex every 12 hours. We also tell patients to massage the area and to stimulate it in order to sort of help get that sort of thawing feeling sort of going away. We also then put patients on this little ladder of oral prednisone. You can see it's basically 60 milligrams for 2 days, then 30 milligrams for 2 days, then 15 milligrams for 2 days, then 7.5 milligrams for 2 days, then 5 milligrams for 2 days, and then 2.5 milligrams for 2 days for a total of 12 days. So most incidents of nerve injury are going to resolve themselves within 6 months. As long as things are getting better, usually I don't refer. If it's the case that things are not getting better, that's where referral is required, and 6 months is your window. The patient may need microvascular neurosurgery or nerve grafting procedures. permanent injury is related to the development of neuritis, and the worst complication for any patient who's had a nerve injury is dysesthesia. So dysesthesia, let's talk about that. So how do you treat dysesthesia? So usually we'll treat dysesthesia with things like tricyclic antidepressants. I had an instructor one time say, don't call them antidepressants because you're not using them for depression, you're using them for pain. So he called them tricyclics. So he usually generally would prescribe 20 to 40 milligrams of amitriptyline daily. And if this didn't work well, he treated it with carbamazepine, Tegretol. So basically treat it like trigeminal neuralgia. And if it's the case that this did not help, the ultimate treatment for a patient who has dysesthesia from a nerve injury is to sever the nerve and make the patient totally anesthetic. And yes, they're not going to be able to feel anything, but with the dysesthesia, they're feeling pain. So in terms of anatomy-related complications, Part C is bleeding. So severe hemorrhage. So good care, Rungchar Sang and Kan reported in 2003 that 24% of all implant procedures had some form of severe hemorrhage. I find this number a bit high, at least in my own practice. But there are arteries and soft tissues and osteotomy preparations. And also remember, in that lateral sinus wall, when you're around the middle superior alveolar artery. So the key is early recognition and avoidance of certain areas like the inferior alveolar nerve or the inferior alveolar artery, the floor of the mouth, which is very vascularized, the submandibular fossa, and also the middle superior alveolar region. Treatment. So treatment of any type of bleeding is going to be pressure, elevation, crush or burnish, tie or ligate vessels, cauterize vessels, and use of bone wax. Other types of anatomical related complications are cortical plate perforation. So fenestration basically leaves bone coronally but exposed threads apically, and a dehiscence, the coronal portion of the implant is exposed. So this can be fixed with a bone graft with or without a membrane, and flapless surgery is contraindicated in cases where there may be a perforation like this. So this is a photograph basically demonstrating fenestration. So you can see there's no bone in the apical aspect, and in dehiscence you can see there's no bone in the coronal aspect of this implant. Sinus perforation. Tatum first described the sinus lift in 1986. Sinus augmentation is a safe and reliable method of increasing the vertical height in the posterior maxilla. However, implant stability is important so that the implants do not get dislodged into the sinus. If you lose an implant of the sinus, an urgent referral to an ENT surgeon is required for functional endoscopic sinus surgery to remove it. And a study by Jung et al. Found that sinus perforation of implants did not lead to sinus complications. Classification of sinus perforations. So you have a class 1 perforation, which occurs at any point along the most apical wall of the prepared sinus window. A class 2 perforation, perforations that occur along the lateral or crestal aspect of the prepared sinus window. And a class 3 perforation that occurs on any location within the body of the prepared sinus window. So other types of anatomical related complications are devitalization of teeth. So a complete oral exam is recommended prior to placement of implants. In particular, adjacent teeth need to be evaluated for vitality and pathology. You want to avoid things that may flare up after implant surgery. You also want to avoid microbial contamination during healing, which can lead to failure of the implant. Dilacerated roots and tipping of adjacent teeth can prevent ideal placement, and these can be prevented by using a stent or intraoperative radiographs. So here's a photograph of the complication we don't want to see. And this can be easily resolved by using something like this, a guide pin intraoperatively. Wound dehiscence. So wound dehiscence can be caused by many things. We can talk about poor flap design, poor surgical technique, poor repair, poor tissue quality, previous surgery in the area, an underlying medical condition, or superficial implant placement. Lack of attached tissue. This is a photograph demonstrating a lack of attached tissue. Part D, iatrogenic complications. So human error. So, we're all human. We make mistakes. Sometimes you have a bad day. So there's all types of things that can happen. So things in surgically, overheating, having a bad technique, losing an implant, errors in judgment, deviations from established protocols, having an eccentric drill, stripping a hex inside a patient, inside a implants which are being placed, fracturing a drill. Patient selection is also important. We all have those, that list of patients who, unfortunately, we tried to help them out, but we kind of wish that we didn't because they were very difficult, that we didn't screen for them, in advance. So you need to know the psyche of your patients, their anatomy. Sometimes we pick patients who we want to work on, and there's anatomical challenges, and retrospectively we say to ourselves, from an anatomical perspective, why did I take this case on? Systemic diseases. A lot of times we work on patients who have diabetes. One of the questions I always ask patients who have diabetes is what is your hemoglobin A1C? Most of them actually know what these numbers are. If a patient says to me my A1C is around 10, does that imply to me that this patient is taking good care of themselves? So if they're not taking care of their diabetes or managing their diabetes well, what's the argument going to be that this person is going to follow the post-operative instructions that you're going to give them with respect to placing, say, 6 to 10 implants in their jaw, and expecting these patients to follow post-operative instructions, make sure things are going to heal, make sure things work well, that these implants osseointegrate, that whatever prosthesis we're going to give them, they're going to take care of, and not end up becoming one of the patients on our list of peri-implant diseases. Part D, iatrogenic complications, prosthetic failures. So you can have a loose implant, you can have excessive bone coverage, you can have exposed threads of implants, you can have cover screw problems, there can be the wrong abutment length, faulty abutment seating, retained sutures in patients, gingival hyperplasia, mobile tissue. Continuing along with this, there's prosthetic failures in forms of aesthetics. We just didn't meet the aesthetic needs of the patient. The patient wanted a certain aesthetic outcome, and we didn't give it to them. Speech. Speech is an important thing to consider as well. We all know about like T's and S's and C's and all types of other letters that we describe whenever we're doing any form of prosthetic for a patient. But this is also very important to take into account when one is placing implants, that we don't forget these basic skills that we learned as part of our fixed and removable programs when we were in undergraduate dental school. Functional issues. Patient comes to you and says, hey doc, I want to be able to chew steak, and you end up giving the guy 2 implants and a removable denture on 2 locator attachments. The patient comes back and says, I said I wanted to be able to chew steak. I can't chew steak with this. So sometimes prosthetic failures are just as a result of not asking the patient what they want to be able to do with the particular prosthesis that they have, or not explaining to patients what the functional limitations of the design that we've selected for them is going to give them. Psychological failures for patients. Sometimes patients just don't want to be dealing with a removable prosthesis. They want a fixed prosthetic, and unfortunately we didn't talk about this with the patient, and they say to us, what do you mean I have to take this out at night? I wanted to wear this all the time. My husband's never seen me with teeth, or my wife's never seen me without teeth. Part D, iatrogenic failures, parafunctional habits. So what tells you that a patient's going to have parafunctional habits? Excuse me. So things like scalloping on the lateral aspects of the tongue. This is a clear felt sign to you that a patient has a parafunctional habit. So what patients generally do is they'll grind their teeth, and they'll brace their teeth using their tongue and grind the teeth, and that's what gives you that scalloping appearance. A fractured implant is also a sign that possibly something is going on. Another sign is a loose implant. Bone loss, that classic scalloping that you see in the coronal aspect of the implant, is usually a result of some form of a parafunctional habit. So I previously have talked about parafunctional habits as being the grim reaper of dentistry. You can do all the beautiful work you want, but if a patient is grinding or bruxing their teeth, good luck. So I price into every patient's treatment plan a bite plate. So if we're doing one of my mentors in dentistry, she basically said, if you're putting even a simple crown inside a patient's mouth, she sends them home with a bite plate. And her basic rationale is she would rather they wear a bite plate and that causes no problems, as compared to doing a lot of expensive dentistry in a patient's mouth, having them come back at recall and finding out that porcelain's breaking, that prostheses aren't functioning as well as they used to, in an implant case that a patient's starting to develop early signs of bone loss, like classic scalloping in the coronal third that you see. So you have to be able to recognize which one of your patients is going to have a parafunctional habit. So the anatomy usually of a patient who is a TMJ patient or TMD patient or patient who has parafunctional habit is going to be as follows. Usually they have a class 2 retrognathic mandible and a head forward position. Sometimes these patients also have an anterior open bite. They have no anterior guidance, and these posterior teeth basically start grinding away because they're trying to find that anterior guidance. Sometimes we see in these patients, there's other signs that there's a skeletal issue. It's things like a bicuspid extraction. This patient had their bicuspids extracted as part of orthodontic treatment because there was a skeletal issue. We'll also see inside these patients flattened cusp tips. We'll see missing or mobile teeth. As we already mentioned, you'll see scalloping of the tongue. These patients also are warriors, and I shouldn't say it's warriors. What I mean is they're symbols of Wolff's Law. Wolff's Law bone forms under compression, and these people have tremendous exostoses in their maxillary mandible. You'll also see things in the teeth like abfraction lesions. Those abfraction lesions didn't just occur on their own. These are those sharp V-shaped lesions. They're not rounded. There's not toothbrush abrasion. This is an abfraction from parafunction. In a panorex, you'll see shortened condylar height in these patients. You'll see distal bowing of the condyles. In an MRI, you'll actually see evidence of joint degeneration. So the treatment for this is get these patients into a bite plate, right? So in our practice, basically we take our impressions, we try to get the patients a relaxed bite, get a relaxed bite registration into our lab, and ask the lab for a hard, not a thermoplastic, not a soft, you want a hard acrylic bite plate to take advantage of that Golgi tendon organ reflex, right? So the Golgi tendon organs inside the muscle basically measures the amount of force in the muscle versus movement. So when it's something hard, like when you bite down something hard, you notice your jaw just snaps open? Same sort of thing. You want a hard acrylic bite plate. You don't want a soft one. A soft one, even the thermoplastic ones, patients can chew through them. And so that Golgi tendon organ, not only does it sense an increasing amount of force, but it senses movement in the muscle. So it thinks, hey, I can actually chew this a lot more. With a hard acrylic bite plate, what happens is the patient ends up, or at least with the Golgi tendon organ inside the muscle, there ends up being an increase in the amount of force, but there's no movement at all. And it takes into account, some people have termed this as the nociceptive trigeminal inhibition. But basically what it is the body has its own natural reflex, so you don't end up breaking your jaw or breaking your teeth, that if the force increases, there's no movement to snap the jaw open and not allow more force to build. And in this sense, so a hard acrylic bite plate with cuspid guidance or some form of anterior guidance created into it is what we try to provide to our patients. The anatomy issues with the TMJ. So you can have things like pain and also occlusal or skeletal issues. So this is the TMJ triad. So a patient may not necessarily have all three of these things. They may have anatomy issues with the TMJ, or they may have pain or occlusal or skeletal issues. It's not necessarily that all three are going to occur at the same time, but this is the triad that one needs to understand. Prosthodontic failures. So avoid premature loading. Try to have a passive fit. Try to have good design of your prostheses. Try to have patients who have good oral hygiene. The loss of integration of the prosthetic. Soft tissue problems that can occur. Make sure that oral hygiene is adequate and maintenance is adequate. And also, there's also good reasons to have retrievable prosthetics versus cemented. Some people said, oh, there's no difference between cemented and retrievable. That's baloney. Patients are developing peri-implant diseases, peri-implant mucositis. You want to be able to take these prostheses off and clean them and treat them if they need to be treated. You also want to be able to deal with things like loose or broken screws. How are you supposed to deal with a loose or broken screw if the prosthetic is cemented without drilling into it and then having to give the patient a new prosthetic? So the framework for the management of long-term complications is as follows. Number one, acknowledge it's a team effort. Here's a proposed framework. History, signs, symptoms, including time of onset relative to the various stages of dental implant treatment. A meticulous clinical and radiographic exam is conducted and compared with records obtained before complications arose. A working hypothesis for the cause of the problem is brought forward. And can the problem be predictably addressed? If so, if the remedy for a given complication is unpredictable or complex, then retreatment should be considered. And this can involve, unfortunately, removal of the implant or prosthesis. And once a complication is addressed and a favorable outcome is achieved, consideration should be given to preventing further complications. So the next lecture is on peri-implant diseases, the unfortunate grand poobah of complications in implant dentistry. Once again, I've provided you with all of the references that we've used in the production of this lecture series. On behalf of the entire team at the Cataraqui Dental Implant Institute, I want to thank you for listening to our lecture.